Hello, good, my dear students. I am Dr. Anshul Diwakar, and today I'm going to introduce you to the resident masterclass that I have created for all the postgraduates in anesthesia. We have been running this program for now almost about 1.5 years, and today I'm going to take you through the journey of what all we have done and what is that we are going to do. So let me introduce you to the current live module. We are a blend of everything that you need in anesthesia residency. We have a program which has a live session at least once or twice in a week to keep you on track, as well as you get all the contents in the pre-recorded form in the app so that you can watch them as many times as possible. And with this current module, I am covering most important 24 topics in the coexisting diseases in anesthesia, along with their notes, how to write in the exam, and a lot of exciting stuff that we do on our dedicated WhatsApp group. If you look closely at the topics, then we have four very important topics from cardiac anesthesia, hypertension, mitral stenosis, coronary circulation, and ischemic heart disease. Anesthetic management of a patient on pacemaker. In geriatrics, we have physiology of the geriatric patient, frailty in anesthesia, which is now in the recent advances, TURP syndrome. In neurology, we have cerebral autoregulation, and we have patient with raised ICP. In pediatric, we have very good topic on neonatal anatomy, tracheoesophageal fistula, meningomyelocele, open eye injury, foreign body bronchus. And then we have a lot of good topics on obstetric anesthesia, like physiological changes in pregnancy, anemia in pregnancy, amniotic fluid embolism, and retained placenta. Along with that, I've included some very difficult topics which are considered as miscellaneous topics, and we are going to discuss them in great detail. Now, you can always contact me on the said number if you want any more clarifications or discounts. This module 4 is available as a 6 months and a 12-month subscription. The good thing is that if you take a 12-month subscription, then even when we launch module 5, you will get access to it till your course validity. Now, what is that I'm giving you extra in this module 4 is I'm giving you all the other sessions that I've taken so far, which is the combined module 1, 2, and 3, which has the most important and yet least taught topic on anesthesia machine, gas laws, breathing systems, airway assessment, difficult airway algorithms, and almost all the instruments that are a part of your Viva as well as for practical purposes. Then we have module 2, which is in respiratory physiology and critical care medicine, which is by far the most famous module of mine, which has covered one of the most difficult yet never taught topics, but it is always asked in the exam. And then we did a detailed discussion of all the anesthetic pharmacology with right from the basics till the most advanced stuff. So you get all of these sessions complementary along with your module 4. Now, what I'm going to do is I'm going to give you a short understanding of how I teach in my class. So the next few minutes, you're going to watch a part of my class that I take normally live, which is available for you to watch. And if you like it, then you can always contact me and we can talk more, and we will take your journey of being an anesthesia resident in India or even in abroad. Yes, we have students from abroad as well, to a next level. It's a blend of conceptual anesthesia teaching along with notes making that will be live. I will write with you all, I will make you write so that you can reproduce the same in the exam. So there are no PPTs that I teach, there are not long descriptions from the books. It is my understanding of anesthesia that I will mix with the way a perfect answer is being written, and it will be delivered to you in that form. So I hope that you like these videos and you enjoy these sessions with me, and I hope to see you soon. All the very best. Goodbye. Now, today I'm going to discuss a topic which in itself scares us the most, and I won't deny, but I have taken a very long time to make this topic understandable, at the same time reproducible. It is a big topic. I'm going to teach you everything, but the questions that come in the exam are very straightforward. Usually they come in the form of describe TIVA and describe TCI. And so at the end of this discussion, I want you all to be in a state where you are able to not only understand the concept of TIVA and TCI, but at the same time be able to reproduce it in the exam. So I have literally dumbed down this topic, because any text that you take for this topic, whether it is Miller's textbook of anesthesia or hundreds of articles that have been written on TIVA and TCI, you will find a very complex language in them, and you will find that all of these topics, all of these articles or chapters, they have these great discussions on the pharmacokinetic modeling and the pharmacodynamic modeling and the names of the models, and what are the covariates that you put, what are the advantages and disadvantages, and there'll be a lot of different types of graphs which will confuse you a lot. So what we are going to do today is we are going to dumb it down to the level that anybody, once they listen to this topic, anybody will be able to talk on Target Controlled Infusion, that is used to deliver TIVA. TIVA is Total Intravenous Anesthesia. And you know what? When you are working as an anesthetist in India, then TIVA is often the term that is miscoined by the surgeons and even a lot of anesthetists when they are doing some case in sedation. So when you do something in sedation, the technical term for that is monitored anesthesia care. That is when you don't do airway management, but you maintain a light level of sedation in which most of the local procedures can be done. But then you normally call it TIVA. Why? Because you are not giving inhaled anesthetic agent, but you only call it TIVA when there is total intravenous anesthesia, that is for the purpose of surgery. Now I've taken few of the pictures and tables from Miller's textbook of anesthesia. This is just to, so the initial 15 minutes I'm only going to talk. I'm only going to try and make you explain the entire concept behind TIVA. And once we do that, then we are going to move forward, and we are going to, talk about the contents of TIVA and also how we are going to approach a question of TIVA, right? So normally when you say total intravenous anesthesia, it is always a combination of an analgesic and a hypnotic. Usually the hypnotic that is used is propofol, and the analgesic used is remifentanil, and these are the two most common drugs that we use in TIVA. Most of the time we use them together. All right. Now what this basically this image is trying to show you is the interaction between the pharmacokinetic and the pharmacodynamic properties of that particular drug in the context of TIVA. Now what is pharmacokinetic property? Pharmacokinetic property is what your body does to the drug. Pharmacodynamic is what the drug does to the body. So the effects, the side effects are seen in pharmacodynamics, and how a drug gets absorbed, distributed, acts and excreted after metabolism is your pharmacokinetics. And if you remember, I have discussed this topic of pharmacokinetics of a drug that are used in anesthesia in detail in general pharmacology in the module 3. So lot of what I am going to teach you today is based on the context in which I have discussed the first order kinetics, zero order kinetics, second order kinetics, the compartment model, the multiple compartment model, the 3 compartment model, the 2 compartment model. All these basic things I have discussed there. So I'm not going to revisit them again. Also because we are only going to discuss the part where we apply TIVA along with TCI. So let's see, when you give a combination of a hypnotic and analgesic, so there is a interaction between the pharmacokinetics and dynamics. You will initially give a dose. That dose will cause a blood concentration. Now the blood concentration decreases by excretion and metabolism, and it gets redistributed in the body. Then you have the effect site concentration. Effect site is like a imaginary space that we have created, where what happens is, what is the concentration of the drug where it is being required. Effect site, where effect happens. So no matter how much propofol you give in the blood, ultimately its effect site is brain. So ideal anesthetic concentration of propofol should always be measured at brain, but it is not always possible to measure in the brain. So effect site is like a place that we have created where if the concentration is adequate, then the effect will come. Then you will measure the clinical effect. This measured clinical effect will go to a computer. Same thing will happen with the analgesic. Now there will be obviously interaction on the pharmacokinetic level between the two drugs. There will be interaction at the pharmacodynamic level between the two drugs. This computer will then give a feedback control which will then adjust the dose. So this is the principle of pharmacokinetic pharmacodynamic interaction, or also called as closed loop anesthesia. Closed loop anesthesia, right? This is something that will be asked to you a lot. What is closed loop anesthesia? So closed loop anesthesia is something where you give the drug, then you assess the effect of the drug. That will cause you to adjust the dose of the drug, which will again cause some effect, which will again adjust the dose. So when you initially give the drug, the level of the drug will rise, the action will come, which will be assessed by the computer. It will realize, okay, now our target has been reached. Now I want to maintain it. It will give the feedback, slow the infusion rate. As the target is achieved, the infusion rate slows, then the target is then undershooted, again the dose will increase, and it is overshooted, again the dose will decrease. This is called as closed loop control of anesthetic agent. When you are giving normal anesthesia, you do that by controlling the dial on the vaporizer, isn't it? So the surgery is going on, suddenly the surgeon again gives a longer incision. Suppose it's an open surgery going on, again the surgeon extends the incision. Suddenly you will say, see, hypertension, tachycardia, if you have a BIS monitoring, you will see the values are rising. You will increase the dose. Again, if nothing is happening, the surgeon is closing up, you have given a good epidural. Towards the end of the surgery, you are practically giving no anesthesia, no inhaled anesthetic agent, and still the patient is very, very comfortable, right? So you have to understand that what you normally do, and you are the person who is judging it. In TCI, Target Controlled Infusion System, all of this thing has been automated and given to the computer. And that is our ideal way of giving TIVA, ideal, where we don't have to do anything. We just put the patient details. Everything has been pre-calculated according to a lot of algorithmic scales and all the pharmacokinetic and dynamic data that we have collected over a large sample size. And then we just sit back and relax. That is your ideal TIVA with TCI. Now, most of the time, we try to understand कि sir इतना मेहनत क्यों करना है? Why do we need to do so much of hard work if we want to give TIVA? Why do we want to give it as an infusion? What will happen if we just keep giving boluses of the drug? That is what we also do. If you are doing something in sedation, suppose there is a DNC that the obstetrician has said it's a 10-minute job, and you decide, okay, what I'll do is I'll just give slight sedation. So what you do is you give bolus doses. Now look at this particular graph. This is time versus CP, which is the plasma concentration, and time versus CE, which is the effect site concentration, right? So what happens? Every 5 minutes, I am giving a bolus dose. Every time I give a bolus dose, the plasma concentration rises, and then few seconds after that, the effect site concentration rises. Again, it falls back. Again, I give the drug. Again, the plasma concentration rises, effect site rises. Again, it falls back. So what you see is that the effect site concentration is waxing and waning and waxing and waning. So this is a very jerky type of anesthesia, isn't it? Where the level will go, it will reach at its peak and then come down. You will again realize, because the patient will be aware, the patient will start moving, the patient will start moaning, the patient will start clenching their legs. Again, the hypertension, tachycardia will happen. Again, you will give the drug. So this is a very jerky type of anesthesia. This is bolus based model. So to avoid that, what we did was we shifted to an infusion based model. Okay. Now these two graphs that you see, these are infusion based model. But one is targeting the plasma concentration, another is effect site concentration. So both the places, what you see in the orange is the plasma concentration, and what is in the blue is the effect site concentration. That is the level at which you will get the desired action. So it's at the level of the brain. So see, propofol plasma or effect site concentration, propofol plasma or effect site concentration. Now what you need to understand is that this is ideal. This is ideal. Where when you give the drug level rises, along with that your effect site concentration also rises, and when you keep giving the drug over a period of time, then they both merge and they come to the same level. But normally what happens is, normally this happens. This is effect site modeling, where your model is based on the effect site concentration. What is that you need at the effect site? And obviously it takes time for any drug to go from plasma to the effect site. So to achieve that level fastest, you have to overshoot the plasma concentration. So you give a very high induction dose, which will cause almost immediate rise in the effect site concentration over a period of time. And then as the plasma level drop, the effect site level will drop, and then when the infusion continues, then at some point they will both come to the same level. That is when the distribution, elimination and your maintenance dosing is the same. So this is how you give TIVA with TCI. Where you are using an infusion system, and this is your TIVA with manual boluses. This is your TIVA with manual boluses. So try to understand the difference between the two. This is much better, isn't it? This is much better. So with this backdrop about TIVA and TCI, let me introduce you to the contents of this particular lecture. And we are going to discuss TIVA along with TCI in following manner. Definition of TIVA, advantages and disadvantages of TIVA, definition of TCI, how it differs from TIVA, the bolus elimination transfer BET model or 3-compartment model. There are 2 models that we use. TCI pumps, little bit of description of how the pump is, how to set up a pump, the drugs and the models used, indications of use, monitoring that is required with TIVA and TCI, potential problems and complications and their troubleshooting, and finally a safety checklist for TIVA TCI. This is the entire topic. Suppose there's a 25-mark question that is asked, or you are supposed to present a presentation in your PG activity. These are the things that you are going to include, which are going to make some sense, right? So this is entire TIVA. Most of the time we talk about these things because the question that comes is usually very vague. Like the last DNB question paper, they give describe TIVA. They didn't even write describe. They gave a 5-mark question saying TIVA. Then I saw a few years back, there was a question that said TIVA with TCI. So what basically happens is that they only give open-ended questions where you have the liberty of answering anything you want. Okay. So let's start with TIVA and TCI, and I'm going to define both of them together. What is TIVA? Is total intravenous anesthesia. Total intravenous anesthesia, which involves total intravenous anesthesia, which involves administering anesthetic agent via intravenous route for both induction and maintenance of anesthesia. So what is TIVA? It is total intravenous anesthesia, which involves administering anesthetic agent via IV route for both induction and maintenance of anesthesia. That is the broader perspective. When you use only IV drugs, that is called as TIVA. So no role of inhaled anesthetic agents, even not nitrous oxide. But what is TCI? This is what confuses us. So TCI means target controlled infusion. TCI means target control infusion, which utilizes the pharmacokinetic models to maintain a steady state plasma or effect site concentration, which utilizes pharmacokinetic models to maintain a steady state concentration of drug in plasma or effect site using a infusion device. So remember, you cannot give TCI without a TCI pump. TCI pump is where all the mathematics that we are going to understand in some time is fed before. We need to understand it because we are anesthetists. We can't give a drug without understanding the logic behind giving the drug. But frankly, there is nothing to understand. If somebody teaches you, okay, for this patient, you use this model, in this model you enter these details and you start, that is the end of story. Then the pump will automatically adjust things and it will deliver that particular concentration of propofol or remifentanil or L-fentanyl at that particular rate, and you don't really have to look at anything except that you keep looking at the monitoring and you keep looking at the BIS, and if you find that the BIS is rising, that means the level is inadequate, so you give a bolus more, otherwise you just keep it running. Okay, all right. So this is the definition of TIVA and TCI. Let's look at the advantages and disadvantages of TIVA. Now, what are the advantages of TIVA? Reduced pollution. We have seen in inhaled anesthetic agents that all inhaled anesthetic agents are actually chlorofluorocarbon molecules, CFCs, and all CFCs are pretty harmful for the environment. So there is a lot of pollution with the use of inhaled anesthetic agents. Better recovery. Better recovery profiles. We know propofol has a very good anti-emetic action. Along with that, it has very good recovery profile. So there is decreased PONV. There is smoother extubation. Then stable hemodynamics. A combination of propofol or etomidate along with remifentanil. It's a very good hemodynamic stability, stable hemodynamics. Then patient comfort. Especially in patients with respiratory complaints, where you have some respiratory issues, their use of TIVA is desirable. But obviously it is not a fail-proof technology. There is always a risk of overdose. And this is when you don't understand TIVA well, when you don't understand the compartments and you don't understand the concept of volume of distribution, clearance, bolus, dosing, elimination, plasma concentration. If you don't understand this, then there is always a possibility that there will be risk of overdose, especially when you have improper infusion rates. Or you have entered the wrong concentration, dose calculation error. Then obviously it has a technical complexity, and that is why most of the people in India do not really know how to give TIVA. We don't know. We have not been taught this thing. Frankly, I have never been taught how to give TIVA. It is later on when you learn by experience or you watch somebody do it. Otherwise, if you tell me that tomorrow I don't have a vaporizer, so give me a very good anesthesia, just like when we give it with even Goldman vaporizer, it would not be very easy, because you have complex infusion pumps which are expensive also. They are not very cheap, and it is difficult to monitor. It is difficult to monitor. Also, there is a risk of drug accumulation, especially when you give over long periods of time. Suppose there's a 6-hour surgery, then we have read the concept of context sensitive half-life. At some point of time, the drug is going to have an increased context sensitivity half-life, especially in prolonged infusions. Especially in prolonged infusions. Then less familiarity with use. Less familiarity with use, and obviously high cost. Less familiarity with the use and obviously high cost. So these are the advantages and disadvantages of using TIVA. Disadvantages of using TIVA, right? So you can see it's very logical thing. What you face every day is what you have to write in advantages and disadvantages. Obviously, advantages that you are using propofol. So all the things that are with propofol, the beauty of propofol is stable hemodynamics, better recovery profile, smoother extubation, and obviously it has absolutely no irritant effect. So the patient is not at the risk of bronchospasm, laryngospasm. It is excellent for asthmatic COPD patients, and in fact the patients have a better CO2 sensitivity, and their respiratory mechanics are better preserved when you are using propofol. So everything that is good with propofol, remember it as advantages of TIVA. And disadvantages why you don't use it, because you always think, what if I give a more dose? There is always difficulty in setting up the infusion pump. There is the risk of drug accumulation, prolonged surgeries. There is less familiarity with the technique, and obviously high cost. You don't get the infusion pumps so easily. All right. How does TCI differs from TIVA? So nothing. TIVA is a method of giving anesthesia. When you give TIVA using an advanced method of delivery of IV drugs, it is called as TCI. So TCI is just an advanced method of delivery of IV anesthetic agents for the purpose of achieving TIVA. TCI is just an advanced method of delivery of IV anesthetic agents for the purpose of achieving TIVA. That is the difference between TIVA and TCI. Now, it differs from TIVA with a manual infusion in two aspects. What is the difference between TIVA and TCI? Two aspects. One is the controlled target concentration, second is the feedback mechanism. So your target concentration is controlled in TIVA, and second is feedback mechanism. Feedback mechanism. These are the two differences between TCI and TIVA. TIVA में क्या होता है, आप टारगेट क्या कर रहे हो आपको नहीं पता. इन ट्रेडिशनल इन्फ्यूजन सिस्टम्स you deliver a constant rate of the drug. Suppose मैं propofol manual infusion से दे रहा हूँ, so what I will do is I will set it at 10 mg per kg per hour. That is what I can do. In traditional systems, which deliver a constant rate of drug, unlike in traditional systems which deliver a constant rate. TCI systems are designed to achieve and maintain a specific target concentration of drug in blood. TCI systems are designed to achieve and maintain specific drug concentration in plasma or effect site. In plasma or effect site. This is the first point of difference between TCI and TIVA. TIVA में बस चल रहा है, आप दे रहे हो, आप ज़्यादा दिमाग नहीं लगा रहे हो. इसमें you can set a specific target both in plasma or effect site or both, which is based on lot of research that has been done on the pharmacokinetic modeling of the drug. Also, there is a system to integrate the feedback mechanism, which is that as the effect of the agent starts coming, you have a mechanism, you have a system in which you use certain depth of anesthesia monitors like BIS, entropy, narcotrend, which will then give a closed feedback loop to the system ki okay, you have achieved your target, now you can decrease your infusion. So TCI systems provide more dynamic and responsive drug delivery. More dynamic and responsive drug delivery by using pharmacokinetic and pharmacodynamic models to continuously adjust infusion rates. So it is very dynamic. It is not fixed. It is dynamic. It keeps on changing. है ना? It keeps on changing. That is the difference between TCI and TIVA. If somebody asks you what is the difference between TCI TIVA, आपने बोला TIVA देते हैं okay, आपने बोला उसको controlled infusion से देते हैं okay. Why? Because you can target a specific concentration as well as you can have a very good feedback mechanism. Now, on what things, what principles TIVA is based? Sorry, TCI is based. Principles of TCI. So it is based on three things: the models that we use, the pharmacokinetic parameters that are usually used in these models, and what are you targeting? What is your target concentration? So the models that we use are, first is Bolus elimination transfer model. This was the first model that was being used to understand how the drug will behave in the body. Bolus elimination transfer. But it was soon realized that the drug doesn't act so easily, and so it was being abandoned. It is still used to calculate the loading dose, to calculate what is the loading dose required for any drug. Now we use something called as 3-compartment model. Now we use something called as 3-compartment model, right? The pharmacokinetic parameters, by the way, all of which we have just discussed in general anesthesia, general pharmacology for anesthetists, that is clearance, volume of distribution, and half-life. These are the three pharmacokinetic parameters that we use to calculate and adjust the dosing. And then a very important part called as the target concentration, what you are targeting, whether you are targeting plasma site concentration or you are targeting effect site concentration. Whether you are targeting plasma site concentration or you are targeting effect site concentration. Now, when you target plasma site concentration, then you want to achieve a desired concentration in plasma. So, you target is plasma concentration. But when you target effect site, then your target is at the site where effect takes place, that is target is brain, because all anesthetic agents act through brain. So effect site concentration is now integrated in TCI models, because ultimately what matters is where the drug is acting. So you only try to achieve the concentration of the drug at the place where it is going to have an effect. Okay, now if you just briefly want to again write, then what is clearance? It is the volume of plasma from which drug is removed per unit time. Volume of plasma from which the drug is removed. What is volume of distribution? It is how drug is distributed in the body compartment. And what is half-life? Time required for concentration, plasma concentration to half. Time required for plasma concentration to half. That is your half-life. That is your half-life. Okay. So these are the principles of TCI. Principles of TCI. Now what we are going to do is, we are going to understand first the target. This is just to make you understand. Obviously, you can't really make this in the exam, but if you make, then it is fine. Okay. Now, this is the difference between when you have a plasma site target versus when you have a effect site target. Plasma site target versus an effect site target. So see, when you have a plasma site target, this is the time and this is the concentration at the level of plasma in microgram per ml, right? So you can see that when you target the plasma site concentration, then you decide, suppose I've decided 5 microgram per ml is what I need. So what will happen from 0, the infusion rate would be set that you achieve this 5 as soon as possible. But when you give it at 5 and you then maintain at 5, the effect site concentration rises gradually. So if effect site concentration of 4 is the adequate concentration for your effect, your action, your time would be somewhere say 180 seconds, but 3 minutes. But see, when you target effect site, now what will happen is you want to achieve this 4 as soon as possible, isn't it? So what you do, you give a large bolus dose which will overshoot your plasma target, but it will make sure that you achieve it in very less time, suppose 30 seconds. This is the difference. If you want faster induction, then you want to maintain an effect site concentration, because that is where the action will happen. There's a difference between you giving the drug and the effect of the drug being observed. And that is why you see time to peak effect. Now, when you start giving propofol, the onset of action is 1 arm brain circulation time 15 to 20 seconds. But time to peak effect is 90 to 100 seconds. Why is it important? Why is it important as an anesthetist to remember there's a difference between plasma concentration and effect site concentration? Suppose you are doing a case under spinal anesthesia. I give the spinal, now I have given a steep head low and there is a high spinal. So what would be the manifestation of a high spinal? So you will see intense bradycardia, hypotension, the patient will complain sudden nausea, the patient will become very anxious, they will not understand because the level will come too up, and initially you will try to oxygenate the patient and see, and then you will try to give a fluid bolus for hypotension, but ultimately you need to give atropine. Now by that time you decide to give an atropine, the heart rate has become 30. So what you do, you push the atropine, you raise the fluid, and then you look back at the monitor. You have pushed the atropine. It is not even 15 seconds. The drug has not even reached from the site of administration to the heart, where it will cause a parasympathetic activity. But the moment you give the drug and you turn, you see now the heart rate has become 28, and you panic, you load another atropine, again push an atropine. Tell your junior to load adrenaline, isn't it? And then what will happen? About 45 seconds to a minute will take for the action of the first atropine to start. And the moment the first atropine action starts, the heart rate starts to rise. So 38, 45, 50, 60, 80, 90. Now the second atropine will start acting. So 90, 100, 120, 140, 160. And now you are panicking. Why? Because now the heart rate has become too high and you see that there is upsloping of STs and you fill up isko. Now if the patient is with poor cardiac reserve, 160 ke heart rate mein the patient will precipitate. Suddenly the BP will rise to 180, the surgeon will start complaining, the patient will say, oh, I can't feel, I'm having palpitation. So you have to understand there is always a difference between plasma concentration and effect site concentration. It's a very common example that I'm giving you. Whenever you give a drug, you should know the onset time and time to peak action. You should have a rough idea that if I give the drug, then it is going to start acting in this much of time. Before that, don't give a bolus another drug. Now we know adrenaline acts very fast. So the moment you give adrenaline, within 20 to 30 seconds, the action will come, but you have to wait for 20 to 30 seconds. Otherwise, what will happen? You will do overdose. So this is how we differentiate between plasma site and effect site targeting. Now let's talk about these models. And this was the first model that was used, which was very simple model called as Bolus elimination transfer model, BET model. It was pretty soon out of vogue, but this was one of the simplified aspects of doing things, which we do every day. We give a bolus. The bolus dose will go and achieve an adequate level in the plasma, which will eventually go and reach an adequate level in the effect site. Then what will happen? The drug will start eliminating from the body. How will the drug eliminate? Two ways. It will start metabolizing, it will start distributing, and then you compensate for that elimination by giving a maintenance dose. So it was very simple: give bolus dose, give maintenance dose based on the metabolism. So what will happen? The first step is a bolus dose of drug is given, which is calculated by target plasma concentration, whatever you want to achieve, into volume of distribution. This is the pharmacokinetic method of calculating your bolus dose. Then second, you calculate maintenance infusion. You calculate maintenance infusion, which would be again very simple. It would be the elimination rate. Maintenance infusion would be equal to the elimination rate. How do you calculate elimination rate? Elimination rate is target plasma concentration multiplied by systemic clearance. वेरी सिंपल, जितना जा रहा है उसको मल्टीप्लाई कर दो, सिस्टमिक क्लियरेंस, ठीक है। एंड देन लास्ट थर्ड स्टेप, बोलस elimination transfer, replace this drug transferred from plasma to peripheral compartment, replace the drug transferred from plasma to peripheral compartment. So suppose you are giving a drug using BET principle. If you are giving a drug using BET principle, then what will happen? The rate of infusion of maintenance will decrease exponentially, finally reaching at zero when there is an equilibrium between the drug that you are giving versus the drug that is going from plasma to the peripheral compartment, the drug that is coming from peripheral compartment to plasma. When there is equilibrium, so the drug infusion rate will become 0. So using this model, eventually the infusion rate becomes 0. The infusion rate will become 0, isn't it? So because the drug is getting eliminated x per second and you are giving a drug which is at x per second, and eventually what will happen, the drug that is getting eliminated, that is going from central compartment to peripheral compartment, it will saturate the peripheral compartment, so there will be an equilibrium between central and peripheral, so the drug transfer will stop and therefore your infusion rate will stop. This is Bolus elimination transfer model, which was the basic model, but there were drawbacks. What were the drawbacks because of which we stopped using it immediately? First, can only be used to target plasma concentration. You can't use it for effect site. Can only be used to target plasma concentration, and it is only applicable in the absence of drug previously administered. That means you are administering the drug for the first time. You are giving the drug for the first time. It is only possible then. That is why more or less now BET principle is used only to calculate the loading dose. That is when you have a target concentration, you have volume of distribution. तो आपको पता है कि loading dose, जैसे कि अगर आपको manual infusion देना है तो normally the loading dose of propofol is 1 to 1.5 mg, 1.5 to 2 mg per kg, and then you start by 10 mg per kg per hour, and then every 15 minutes you decrease it by 2 mg per kg per hour. So that is the bolus dose that we have calculated is basically calculated using BET principle. But if you have to use a TCI system, then now we have switched to this 3 compartment model. We have switched to this 3 compartment model. Now what happens is, here the drug is distributed between 3 compartments. And we have discussed about this 3 or multiple compartment model in detail in general pharmacology for the anesthetist. And see what happens when you administer the drug. The drug first reaches the first compartment V1, which is the central compartment. From here it will go into 2 compartments. One V2, which is a rapidly equilibrating compartment, and then V3, which is a slow equilibrating compartment. Okay, and from central compartment it will go to effect site. It will go to effect site. Now for every transfer there will be a coefficient, the factor that is going to decide the transfer from one compartment to another, which is primarily based on the drug concentration, but it is also affected by the lipid solubility of the drug, the lipid component of the concerned compartment, the cardiac output, the regional blood flow, and the avidity with which the drug binds to the receptor in that particular organ. So you describe these constants as K. So K13 means a factor that is going to decide the transfer from compartment 1 to compartment 2. Similar 1 2 3. From 3 to 1 will be K31. Similarly K12, K21, and then you have K10 which is going out of the body, and effect site is K1E. From effect site to central compartment is KE0, and this is the parameter that is going to decide the decrement time, and this is the parameter that will decide after how much time of your infusion is when you will start seeing the return of the patient to consciousness. Okay, so this is the three compartment model. Now for each compartment there is a rate constant, so there is a complex calculation, and this is what these days the TCI pumps they will do. Now ultimately what is happening with all of this is you need to integrate the pharmacokinetic and the pharmacodynamic modeling. The whole purpose of doing this thing is to integrate. Now what it integrates, it integrates the pharmacokinetics of a drug, that is what the body does to the drug, with the pharmacodynamics of the drug, what the drug does to the body, to predict the behavior and effect. So it uses the pharmacokinetics and pharmacodynamics of the drug. Pharmacokinetics and pharmacodynamics of the drug to predict its behavior and effect. This is the integration that TCI does. This integration achieves two things. It is used to achieve the desired concentration in the effect site and to maintain it. What is important is to maintain it, and it helps in real-time adjustment. It is used to achieve target concentration at effect site and maintain it, and provides real-time adjustment. It provides real-time adjustments to maintain the dosing according to your target. To maintain the dosing according to your target. All right. So this is about the basics of TIVA and TCI. Basics. देखो सब हवा की बातें हो रही हैं. Ultimately, it is all mathematics. TIVA TCI is a topic जो actually में anesthetist का नहीं है. It is all about mathematics. And then if you open any article, you see there are a lot of mathematical modeling, and there are big equations that are being given. And if you start reading them, you will try to understand, and you will actually be able to understand it, but ultimately we can't reproduce it in the exam. So I have eliminated all that part where there is so much of calculation, because we will never be asked to calculate it. We will be asked to write about TIVA, and rarely we are going to be asked to describe a TCI pump in the exam. Suppose it is kept in the table viva. All right. So this is about the basics. Now let's look at the indications of TIVA. Indications of TIVA. Okay. Now, indications are all the contraindications of using inhaled anesthetic agents. So we can divide them into three categories: absolute, essential, and choice. This is just to remember and make it attractive in the exam. ऐसा कुछ division है नहीं, but just to make it attractive for the examiner in the exam. Absolute is only one, that is when you have a known case of malignant hyperthermia. because that is the condition where you want to not use the volatile anesthetic agents. So your maintenance of anesthesia by default has to be done using IV induction agents. And in neuromuscular disorders, especially in pediatric, which are having high risk of developing MH, neuromuscular disorders, which are at high risk of developing MH. These are the two absolute indications. Apart from that, most of the indications are essential indications, like patients with long QT syndrome, patients with long QTC syndrome, patients with history of severe postoperative nausea, vomiting, severe PONV, then tubeless ENT surgeries, or tubeless thoracic surgeries. If you don't have a tube, how would you deliver volatile anesthetic agent? So you use TIVA. Then neurosurgery with raised ICP, and whatever TIVA you are going to use, you are going to use practically in your PG in neurosurgeries only, because those are the people, they always piggyback their inhaled anesthetic agent along with TIVA. The reason being very simple, that inhaled anesthetic agents are not so good for neurophysiology. They both increase ICP as well as they cause a lot of nausea, vomiting later on, which can increase the ICP. So usually what they do is they put a propofol infusion. They don't really use a complete TIVA, only at few centers, but most of the time it is a BIS guided combination, less than 1 mAc of inhaled anesthetic agent and something using a propofol infusion. Then surgeries requiring neurophysiological monitoring, then myasthenia gravis, or patients where you have neuromuscular disorders, which we have already seen. Non-operating room anesthesia, NORA, very important reason, and that is what we normally called as TIVA, is actually NORA. Okay. Then if you have to transfer the patient between one environment to another, transfer of anesthetized patient between environments, daycare surgery, and patient's choice. So most of the indications are essential only, and finally choice is to practice a skill. Where do you want to use it? Where you want to practice a skill. You want to practice a skill. Okay, so that is your choice. You want to learn a skill, you want to keep remembering it, so you use it. That is also one of the indication. आज हम टीवा करेंगे, ऐसा मॉर्निंग में एक कंसल्टेंट आया, आपको बोला टुडे वी विल डू टीवा, whether there is an indication or no indication, that is just to keep him in practice. Okay, so these are the indications of TIVA. Now let's have a look at TCI pumps. Now I'm not going to go into great detail of these pumps. Obviously there are a lot of YouTube videos where they have described how to set up a pump. Now we are never being asked these questions in theory, so I'm not covering it. Also, setting up of a TCI pump is something practical. So agar aapke institute mein you have TCI pumps, then you can set it up, you can start using them. Otherwise you can simply watch the video so that you know about it. Now let's talk about the basics of a TCI pump. It is a sophisticated infusion device designed to deliver anesthetic drugs at variable rates to achieve a target concentration at effect site. So what is the basic? That it is a sophisticated device, delivers IV agent at variable rates, variable infusion rates, to achieve desired concentration at effect site. To achieve desired concentration at effect site. Now every TCI pump has three components. It has three components. It has a pump mechanism. It has a computer interface. And it has a user interface. It has a user interface, right? What are the key features of a TCI pump? Key features of a TCI pump is a part where you can input the patient data. So there is a patient data input which is used for input of patient variables like weight, age, sex. So you have a part where you can input the patient data. Then you have target concentration settings. What are the targets that you want to achieve? So it differs, right? If you are using single drug TCI, then the target will be different if you are using 2 drug TCI or 3 drug TCI. So therefore you set the target concentration, and whether that target concentration is plasma site or effect site. CP and CE. CP or CE. Okay. Then you have a part where you display the infusion rate along with total drug delivered, total dose delivered. Then you have options of alerts and alarms that you can set, that can be based on infusion rate, the pressure in the syringe, and the alarms whether you have reached the total dose, the max dose, the toxic dose. And then you have a drug library with pharmacokinetic models. So whether it is propofol, so you will give an option of Marsh, Nider, Eleveled. Then you have Minto model for remifentanil. If you are using pediatric, then it can be Pedfuser or Kataria. So you get the name of the drug and the model along with it, right? This is how it looks like. So you can see that there is a pump mechanism, there is a computer display, and then here is the user interface. Okay? Then you have the manufacturer of the pump, you have the model, you have the effect site concentration, and rest of the things are all put here. You can see lot of images like these in the articles and even in Miller's textbook of anesthesia. And this is something which is very common. In fact, these are the same pumps which are there in your cardiac ICUs, just we don't use the TCI part of it. When you have a cardiac case and you see this so many pumps which are there, then you don't really see, but they all have a TCI mode. So if you go and you start playing with it, you will often find a TCI mode. Now this is just to try and make you understand about the TCI. So what happens? You first need to have knowledge of the drug pharmacology, covariates and therapeutic windows. Okay? So that is the anesthetist part. Then he sets the target and infusion algorithm, which will start the infusion rate. Infusion will go to the patient. There will be a clinical response assessment, which will be the real-time display of drug concentration, BIS, and patient's clinical parameters, based on which the anesthetist will readjust, and there will be a pharmacokinetic simulation. The microprocessor will change certain things, and this is the closed loop anesthesia of TCI. Closed loop anesthesia of TCI. Let's look at the drugs and the models used. Now, I'm not going into too much of detail of these things. In principle, any IV induction agent along with opioid can be used. So we have propofol, etomidate. Thiopentone hasn't really been used because of its very long context sensitive half-life, but we have used propofol, we have used etomidate, we have used midazolam. In opioids, we have used fentanyl, remifentanil, L-fentanyl, sufentanil, and we have manual infusions में morphine, but we don't really use morphine for TCI, again very long acting. We can also use opioid free anesthesia, which we discussed last time. So you can avoid opioids altogether, but the most common combination used is propofol and remifentanil. Propofol and remifentanil. Okay, propofol and remifentanil. Now, because these are the two drugs that are most commonly used, therefore we will discuss the names of the models that are used to deliver these drugs. So propofol and remifentanil. Now obviously propofol can be used for adult as well as pediatric TCI, which have different models. In adult, we talk about the three basic models: Marsh, which was the first model, then Schneider, and now we use something called as Eliveld. Then you have pediatric में Kataria, and now we use Pedfuser. ठीक है. Now Kataria was for age group between 3 to 16 years. So थोड़ा limitation था because the minimum weight was 15 kg. तो you cannot use it in neonates. तो अब Pedfuser है which is from 0.5 or 1 to 16 years and the minimum weight is 5 kg. So more or less it can be used in all age groups. Remifentanil uses a model which is called as Minto model. And the pharmacokinetics of remifentanil are quite different, which we have discussed in detail in the opioid chapter. And so we use Minto model. Okay. So this is just a basic understanding. These names are very, very important. These names are what are going to be asked in the exam. Now, because I know that if I don't teach more than this, then you will say, sir, आपने main बात तो की नहीं. We talk a lot about Marsh model and Schneider. We have heard its name, but we have no idea. So I'm giving you a brief description of what these models mean and what are the things that we look for. So ultimately, our target is pharmacokinetic properties, which we have discussed. BET model, 3-compartment model. अब लोगों ने क्या किया? They sat down and they start doing experiments in normal individual. तो उन्होंने normal individual को लिया, एक large subset of population लिया, say 20 years से 80 years तक, and they started giving different infusions either for achieving anesthesia or for sedation, unconsciousness, recovery profile देखी, accumulation देखा, बहुत सारा duration देखा, whether for short surgery, long surgery, induction, complication, सब चीज़, and उसके basis पे they worked on certain models, and these are the models then were then fed into the software of the TCI. So when you go and select the model, then that particular model asks you for that particular covariates that are used in that particular calculation, and based on that it will calculate the infusion rate, but you will set the target plasma concentration. So Marsh was the first model that was used, and we know first model है तो उसके अपने limitations हैं. Age बहुत बढ़िया थी इसकी, more than 16 years, because they did not have data for less than 16 years. So they started using it by default from more than 16 years. Target was always plasma concentration. Easy था, पहला था, इनको लगा plasma concentration से काम हो जाएगा. Advantage क्या है? Faster induction due to large V1. इसके कैलकुलेशन में जो सेंट्रल कंपार्टमेंट का वॉल्यूम है बहुत ज़्यादा था. So that is why the induction dose that was calculated was too big and therefore it caused faster induction. But disadvantages क्या हैं कि higher loading dose required. इतने की ज़रूरत नहीं थी, but because it had a large V1, therefore higher loading dose was required. Schneider was a better, it was an improvement over the Marsh model, and it had a age group between 25 to 81 years. इसमें large subset of population था, लेकिन minimum age और बढ़ गई, 25 years हो गई. It had a effect site targeting, and the advantage was lower induction dose, and so decrease adverse events. Lower induction dose and therefore decreased adverse events, but it had a problem with age group as well as weight. Inaccurate dose prediction in obese. Inaccurate dose prediction in obese, and therefore later on there was introduced a concept called as allosteric calculation or allosteric dosing, where you could calculate the dosing based on the actual weight of the patient, that was the lean body mass of the patient, rather than the actual weight of the patient, lean body mass calculation. And the pioneer of that was Eleveld, which used lot of parameters while they were talking, and therefore it was used for a very large subset of population, 0.5 years to 88 years. It can target both plasma as well as effect site. And the advantage was that it has a universal pharmacokinetic pharmacodynamic model, so it is pretty much applicable to all age groups. And it was adjusted to concurrent use of opioids. So suppose you are using, suppose कि आप करोगे use, so it was adjusted to the concurrent use of opioids, because if you are using opioids, then there is synergism between use of opioids along with propofol, and therefore your target dosing will change. Your target plasma concentration or effect site concentration will change, which was not taken into consideration with Marsh and Snyder. So if you are using opioids, वहाँ पे क्या हो जाएगा, overdosing हो जाएगी, but यहाँ पे it is adjusted. And the disadvantage was there was less evidence of pharmacodynamic modeling. It was not very robust, less evidence with the pharmacodynamic modeling, and there was underrepresentation of data set between 12 to 25 years of age. Underrepresentation for 12 to 25 years in data set. Underrepresentation for 12 to 25 years in data set. So this is just to make you understand कि अगर आपसे किसी ने पूछ लिया मॉडल्स और उनका डिस्क्रिप्शन, तो ये लिखा ना यार, और इससे ज़्यादा कोई कुछ नहीं पूछ रहा आपसे, ठीक है. So this is about the drugs used and the models. Now obviously you cannot have TCI or TIVA without adequate monitoring, because if you want this system to be true closed loop system, you need to have monitoring. Now monitoring can be done at 3 levels. One, that is commonly we do vital signs. Second is to use depth of anesthesia monitors, and third, clinical signs that are shown by the patient. So monitoring, you start with heart rate, then you have blood pressure, you have pulse oximetry, you have ET CO2, you have a respiratory rate in case the patient is spontaneously breathing. Then depth of anesthesia, you use BIS, which is most common used depth of anesthesia monitor, and it helps titrate the adequate depth of anesthesia. You can use entropy, which is also depth of anesthesia monitor, and something called as a narco trend, which is also a depth of anesthesia monitor. And finally, clinical signs, which are supplementary to electronic monitors. Clinical signs are supplementary to electronic monitors. Supplementary to electronic monitors. Example, patient movement, lacrimation, hemodynamic change, patient movement, lacrimation, hemodynamic change. Now we know the interpretation, but we'll just complete it by writing what will heart rate tell us. It will indicate the cardiovascular response to anesthesia. Cardiovascular response to anesthesia. BP assesses hemodynamic stability. Pulse oximetry reflects oxygenation, which is very important, especially when you are not using airway. Reflects oxygenation. Adequacy of ventilation by EtCO2. Adequacy of ventilation by EtCO2. And respiratory rate indicates respiratory depression or inadequate ventilation. Respiratory depression or inadequate ventilation. ठीक है? So this is how you monitor using TIVA. Monitoring that is used in TIVA. Now, why do we monitor in TIVA? Again, we want to create a closed loop system. So monitoring serves two purposes. Monitoring serves two purposes. What are they? First is that it gives you this continuous feedback loop. It gives you this continuous feedback loop for real-time adjustment. For real-time adjustment of the dosing. Secondly, it acts as a safety protocol. You are giving these drugs in an infusion. You need to be aware of their safety. So they will act as necessary alarms and backup systems can be activated. Backup systems to be activated. Okay. All right. Now you would say, sir, ये कैसे होता है, समझ में नहीं आया. So look at this graph. Now this is a very unique graph. This is, on one end we are talking about the bispectral index, which is frontal processed EEG, which varies from 0 to 100, 100 representing an awake state, 0 representing isoelectric EEG, that is very deep level of anesthesia, almost no brain activity. And this is propofol concentration in the plasma, When it is orange, it is in the plasma. When it is blue, it is on the effect site, and this is the time. Now see what happens. When you start the infusion, what will happen? The drug will rise in plasma and then followed by effect site. When the drug rises in effect site, what happens to the BIS? See, initially BIS was here. When the effect site concentration is highest, the BIS is lowest. Okay? When the drug concentration is highest in the effect size, BIS is lowest. As BIS will start rising, what you will see that the plasma, the effect site concentration will start falling. It will reach a point where whatever you have said, suppose it comes to around here, which is 40 to 60, automatically after that the systems will start increasing the infusion rate and the effect site concentration will increase because the plasma site concentration is increasing. Again, at the highest effect site concentration, you get the lowest BIS. So this is how a dynamic real-time system will work, that with changing levels of BIS, your infusion rates will keep on changing, and that is why monitoring is a very essential part of closed loop anesthesia, that is the TCI that we are using for administering TIVA. Let's talk about potential problems, complications and their troubleshooting. So what can be the potential problems? There can be equipment malfunction. There can be equipment malfunction, which is actually not so uncommon. It is one of the commonest thing. What you can do is you can check connections. You can avoid kinks in the IV line, in the infusion lines, and switch to backup pump. Switch to backup pumps. Then you can have inaccurate dosing. You can have inaccurate dosing. So double check your inputs always. Before putting any dose concentration, always double check it, whether it is 1% propofol, 2% propofol, whether your target plasma concentration is 8 microgram per ml or it is 10 microgram per ml or it is 4 microgram per ml, whether you are using single drug TCI or 2 drug TCI, and verify drug concentration. And recalibrate TCI pump. They need to be calibrated from time to time. So if you feel that there is some problem in the administration, you recalibrate it. Then if you have airway problems, if you have airway management difficulties, then follow DAS guidelines. Difficult Airway Society, difficult airway guidelines, which also we have discussed in detail. Follow DAS guidelines. Okay. So these are the potential problems, which are the problems with your infusion pumps. It can happen at so many levels. See, main sources of potential errors in pharmacokinetic model driven drug delivery. So what can happen? There are three things. There is a host computer, there is a device, and then there is a patient. Problems can happen at each level. What can happen? There can be a problem in the pharmacokinetic modeling infusion algorithm which is put in a software, and the host computer can have power failure, hardware bug, software bug, algorithmic error, communication error. You can have incorrect concentration which can cause incorrect delivery, malfunction, communication error. You can have IV line disconnection, pharmacokinetic change, pharmacokinetic variability, and sampling error or assay error. So these are the levels at three levels: at the level of the software, hardware, at the level of the device, and at the level of the patient. Okay. What are the complications that are associated with TIVA? So there is always a risk of over sedation. There is always a risk of over sedation. How would you recognize it? and then how would you manage it? So over sedation, how would you recognize? There will be decrease in respiratory rate and BIS if the patient is spontaneously breathing, decrease in saturation because of decreased breathing. What you will do? Decrease infusion rate. You will provide ventilatory support. And you will use reversal agents if required. So you can use naloxone, you can use, if you're using midazolam, you can use flumazenil. Hypotension. So what you will see? Decrease in blood pressure. You will give fluids, vasopressors. You will give fluids, vasopressors. Then you will have bradycardia, especially with propofol. You see intense bradycardia, which can also be a sign of propofol infusion syndrome. Decrease in heart rate, decreased infusion rates, and you can give IV atropine. You can have awareness. Suppose you are giving inadequate awareness, what you will see? You will see increase in heart rate and blood pressure on the monitor. You will see patient movement and autonomic response. So what you will do? You will increase the infusion rates. You will add anesthetic agent. And you will do BIS monitoring. You will do BIS monitoring. Okay? So this is about the complications that can be associated with use of TIVA and TCI. Complications that can be associated with the use of TIVA with TCI. So this is the part that I wanted to discuss with you all. Now there is a small thing that I want to tell you, that there is always a difference between what you deliver and what is actually present in the patient. So what we do is we tend to always think that what we have calculated and what we are giving is what the patient will achieve. But that is not always so. It doesn't really always happen that way. Okay. So remember that there is always going to be a difference between the target concentration, actual achieved concentration, and you cannot always measure actual achieved concentration. You can do lot of pharmacokinetic modeling and you can decide कि okay इतना infusion इतने rate पे देंगे ये होगा, but you can never be guaranteed. So there is always an element of error, which is the mean error, and you can never get a system with 0% error. There is usually a 20 to 30% error when we are using these TCI pharmacokinetic models. Also, one thing that you need to understand is when you are using two drugs, you can never combine these two drugs in one infusion. So you will have multiple pumps which will then integrate and give the drug. So there is going to be an integrated model where you are going to put in that there is another infusion going on, say propofol, or you need to know that when you use propofol with remifentanil, then the concentration of propofol required would be lesser. So what you put as a target concentration would be lesser. Okay. Now I know there is always this dilemma in the mind कि sir ultimately हमको तो TCI pump मिलेगा नहीं, so how we are going to use it? So this is a very good table given in Miller's textbook of anesthesia, which tell us the manual infusion schemes. So for anesthesia, obviously the dose required would be higher as compared to sedation or analgesia. So if you look at propofol, the loading dose is 1 to 2 mg per kg because it is given in micrograms. So 1000 is 1 milligram, and then infusion is 50 to 150 microgram per kg per minute, and for sedation it will become half to 1/4 like this. Similarly, if you look at remifentanil, loading dose is 0.5 to 1 microgram per kg and maintenance is 0.1 to 0.4 microgram per kg. So this is a very good place where you can just have a look at the Drugs, their loading dose, maintenance dose for manual infusion in anesthesia and sedation and analgesia. Now something which if you can remember, then it is very good, and you can write certain points from this particular table. What is the checklist for setting up TCI systems? So this is a checklist. Every time you set up a TCI, you need to follow this checklist. So use only dedicated pharmacokinetic TCI pumps. There are different brands, different companies which make dedicated pharmacokinetic TCI pumps. Ensure that you are trained in use of chosen pump and pharmacokinetic model. That is also very important. Ensure that the pump has been serviced in the past 12 months. Ensure the pumps are plugged into mains and they are not on battery. Make sure that the batteries are charged. Ensure that the drug dilutions are correct and entered correctly into the pump. Ensure correct syringe type, size data are entered and the syringes are mounted correctly. Of course, there are alarms for everything. Ensure that the pump is programmed for the drug actually attached to it, and not that कि आप propofol लगा रहे हो but आप remifentanil का model use कर रहे हो. Ensure that the low and high infusion pressure alarms are set to warn of disconnection and tissued cannula. से को दोनों possibility है. निकल गया, suddenly there will be a very low pressure. IV out हो गया, suddenly there will be a very high pressure. Ensure that the patient data entered is correct. Consider if the targets are set appropriate to patient's age and ASA status, and what is the plan B in case of pump failure, right? So these are the checklist, and I'm going to remove this, otherwise this creates a problem in the PDF. And this checklist, you can actually think every day you do this for all the other drugs that you give, for all the other methods of anesthesia that you practice. Okay. Now recommendations for preventing technical problems with TIVA. Complete the TCI system checklist that we just did. Affix the IV cannula firmly on the patient's skin. Keep the site of TIVA infusion visible so that disconnection, leakage or tissued cannula is readily detected. Use only dedicated 2 or 3-way TIVA sets which incorporates anti-siphon valve on drug administration line, non-return valve on any fluid line, and minimal disc space distal to the point of agent or IV fluid mixing. Only use lower lock syringes for administration of drug so that the drug doesn't get spilled out, as well as you don't inject air. Do not label remifentanil syringe until the drug has been added to the diluent. Always check the infusion site if the pump alarm except syringe empty, infusion paused or mains failure, and flush TIVA drugs from dead space of a 3-way administration set before connection to the patient cannula out of the cannula at the end of the case. So these are the recommendations for preventing technical problems which we just saw before we use TCI with TIVA, right? So this is a very close to my heart topic because it has taken me a very long time to understand, and my references are a lot of articles on TCI, but my main reference was Miller's textbook of anesthesia for the modeling and the pharmacokinetic part, and there are few articles that are available. The anesthesia tutorial of the week is also a very good and very legible article, and there are few more articles. And this is a very highly advanced technique. I've also not covered the individual aspects of each model, whether it is Eliveled or it is Marsh or Snyder, and how to set up. And you know, this is one of the topics which is not practiced a lot in Indian theaters. It is something which is now very specific to the Western population. And so don't worry about it. We have just tried to cover the basic, and all these things can be very easily reproduced in your theory exam. And my target of teaching you is that 1, you should know the concept, 2, that you should know and remember the entire topic, but at the same time I want you to go and write it in the exam. And this is exactly what we are doing in our resident masterclass, as you are aware of all of this. And we take each topic, we try to understand its concept, but at the same time we want to make sure that we go and reproduce that perfectly in the exam. So this is a perfect example of how to reproduce a complex topic like TCI and TIVA in your exam. So I wish you all the very best, and you know how to contact me, and you know the details, and you know you can ask me doubts anytime, both personally on DMs or in the dedicated WhatsApp group that we have. And I hope you are following the routine. We are doing now more than 1 class per week. We are trying to increase the frequency, and we are going to maintain a tempo which is going to take you towards your exam in a very positive frame of mindset, right? So my best wishes to all of you, and I hope you like this session. Please do give me your feedback about this session, and if you want me to add something or you want me to again explain something, I'll be happy to do that. Thank you so much, and God bless you.